Rachel.
Hi there.
Hi, how are you?
I'm good. How are you?
Good. So one person on, but just I'm not going to do video of myself tonight. My little boy has been was sick, and then his fever came back today. So
Oh,
yeah, it's been crazy with like a telehealth visit today, and he could come walking in here any minute, and I mean, like, it's been like I've been mommied out the whole day because he just has not been feeling well. So we're trying to figure out what's going on.
no. Oh, baby.
I know. And he's, he's 5, so he doesn't quite get it. So anyways, hi. So that's been my afternoon between homeschooling, a telehealth visit, and fevers. I'm like, ah.
Oh my gosh. Yeah.
Yeah. Especially during this time, it's scary. It's, you start to worry,
Of course.
But you have,
how could you not?
yes, I love your background. Looks so nice. And
Thank you.
You're welcome.
I flipped to my Boston thing. I don't know if you can tell from the people who've registered if it's largely a local crowd or you don't know.
I don't know. Once I, we capture email addresses, and then I kind of look at our database as well to see if they're new folks. And then if they're not, I'll be going to be reaching out to them after the series. The whole entire series has concluded. I'm going to, let me just screen share. So what I'll do is I'll introduce myself, and then I will, I have a couple quick slides, just do a quick overview of Oneinforty, and then I'll introduce you, and then I'll stop my share, and then you can start your screen share. Does that sound good?
Okay, that sounds good. And now remind me the time. I'm supposed to be done talking at what time?
Well, I'm going to say a total of 45 minutes, like from beginning to end. So we'll try to wrap up by 7:15, unless you have more content than that. But if not, then, so figure about like 25 minutes. And I have a couple questions that were already fed to us. We can go through those if you don't cover them in your talk. And yeah.
What are those questions? Because I can try to make sure I work them in.
Sure. Well, they're on my slides. Hold on one second. This is probably what we're going to talk about already. How are visits handled now? Does my insurance cover testing? What was the other one? Like, let me, I have somebody on the line, so I can't pull up my slides without screen sharing. Oh, well, maybe I can. Hold on one second. Let me see. Okay, so how do I find a genetic counselor during this time?
Got it. Check.
How is testing being done during COVID-19?
Check.
I just found out I'm BRCA positive. What should I do?
Check.
What about at-home test kits?
Check. Is
testing covered by my insurance?
I'll make sure I mention that.
Perfect. Yeah, I have a slide on that, and if you want to embellish on it when we get to that slide, that's fine too. I'm just going to put my screen share because folks are starting to come online. Oops. We'll start in about 5 minutes, everybody. How are you and your family, Jill? Good? You guys all hanging in
Yeah,
there?
we're,
Okay.
we're
Weathering it.
okay.
That's good. That's good. That's good. That's what we want.
Yeah, it's just a stressful time for everyone, even when, if things are personally okay for you at any given moment, chances are they're not for someone that you know.
Exactly. And it does affect you some. Yeah. Yeah, exactly. I know if, I know two people that have it, so I do understand. I'm just going to put myself on mute and then kind of wait for folks to log in, call in, and then we'll start at 6:30. Okay.
Okay, that sounds great. Thank you.
Okay. Yep. You're welcome. Good evening, everyone. I hope everybody's doing well. We're just kind of, people are starting to log in. I wanted to briefly introduce myself. My name is Allison O'Hara. I am the co-executive director for Oneinforty. I wanted to thank you all for taking the time to join us today to learn about the recent updates in genetic testing and screening during this time. I know it's a little challenging as we are all trying to adjust to this new normal. This is Oneinforty's second virtual event, and we're very excited to have Jill Stopfer this evening. We've allotted about 45 minutes for this evening's webinar. We hope you join us for the entire session, but if not, a recording will be made available in the next few days on our website at oneinforty.org. We do have questions that have been previously submitted, but if you should have any additional questions during the webinar, you can use the Q&A in the lower portion of your screen. We will try to get to as many as possible, and if we can't get to your question, we'll follow up with you after this webinar. You can also reach out to myself directly. I wanted to, hold on one second. I wanted to also thank our sponsors that made today's webinar possible: the Allergan Foundation, Pfizer, New England Development, AstraZeneca, Clovis Oncology, Tesaro, and Goldstein and Billido. So before I introduce Jill and she gets into her talk tonight, I wanted just to share with you a little bit more about Oneinforty and why Oneinforty. So why Oneinforty? In 2016, our founder, Lauren Kordak, who's pictured here on the slide, sought genetic counseling and testing. The screening showed that she had inherited a mutation in her BRCA gene from her dad that put her at much higher risk than the general population of developing breast and ovarian cancer. She was advised to have risk-reducing surgery, but it was too late. She already had stage 4 ovarian cancer. Given her family history of breast cancer and her Ashkenazi Jewish heritage, Lauren should have had been referred to a genetic counselor and screened for the BRCA gene mutations many years ago. In fact, many Jews of Eastern and Central European descent, which Jill will get into, are not aware that they have a 1 in 40 chance of having a mutation in their BRCA gene that puts them at much higher risk than the general population of developing breast, whether that's male or female, ovarian, prostate, and other hereditary cancers. 1 in 40 is dedicated to stopping BRCA-related cancers in its tracks. We are a nonprofit organization that raises awareness of the 1 in 40 risk to Ashkenazi Jews of inheriting a BRCA gene mutation, and we provide the support individuals and their families need to effectively manage their cancer risk. I would now like to introduce Jill Stopfer, our guest speaker this evening. Jill is the Associate Director for Genetic Counseling at the Dana-Farber Cancer Institute and an adjunct associate professor at the Massachusetts General Hospital's Institute of Health Professions. In addition, she was among one of the first genetic counselors in the country to focus primarily in oncology and has worked over the years on numerous educational and policy initiatives. She counsels individuals and families with hereditary risk to cancer and works on a number of research projects looking to optimize the way genetic counseling is offered. In addition, Jill also serves on Oneinforty's medical advisory board. So Jill, I'll stop sharing and you can start.
Great. Well, thank you so much for that nice introduction. I'm going to share my screen now. Okay. All right. Can you see my slides?
Yes.
Excellent. Okay. So today what I'm going to do is talk a bit about genetic testing, especially for the Ashkenazi Jewish community. Talk about in general, why is this important? Why would someone want to do this for those of you who have not done this yet? I'll try to address everyone at all levels, people who know about it because maybe they've already been through the process, as well as people who are just entertaining getting their own testing themselves. I also included a slide of Lauren. Lauren is one of the most inspiring women that you'll ever meet. She took a very difficult situation and she put all her energy and her talent and made this organization, Oneinforty, out of the need to feel like this should not happen to one more person. And I think of and am inspired by Lauren all the time. And we hope that awareness that BRCA mutations in the Jewish population is something that can be dealt with. It is something where we have an opportunity to change outcomes in many cases. I hope that you'll have a sense of that through this presentation today. So I'm going to start by talking just a little bit of background about Genetics 101. Hopefully it won't be too much like a bad biology class you had in the past, but I hope to kind of bring you into our world so that it makes sense. We'll talk about what is hereditary cancer risk and how do we suspect it? How do we try to recognize it in the family? We'll talk about the specific link about the BRCA genes and Jewish ancestry and what's up with that. We'll talk about the significance of having a mutation in a BRCA gene. What does it mean and what are the opportunities to do things differently? And throughout, we'll specifically be talking about doing testing and screening and all of this in times of COVID-19. So for starters, just so everyone's on the same page, most of us have heard about genes and genetic material and so on. What a gene is, it's really just a little stretch of DNA. And it's a stretch of DNA that is spelled with a genetic code. And when the genetic code is spelled correctly, literally like spelling a word correctly, it's understandable. If a word is spelled correctly, you can read it. If a gene is spelled correctly, it is providing a message to produce a protein. And so if the gene is spelled correctly, you get a functional protein. And if there's a harmful change in the genetic code, you're missing that protein. And that's what sets you at increased risk for cancer. And so when we do genetic testing, I like to talk about it as a spell checking process. So here I just have represented two different genes and how we do our spell checking. And I don't have actual letters of the genetic code. I just have alphabet letters just to make my point. The gene on the left is spelled, quote unquote, correctly. Here you can see it's theater is spelled correctly. And then the gene on the right is misspelled. There are two letters that are out of place. That spelling THXQ, that doesn't say anything, it doesn't mean anything. And so that's what a mutation literally is in the genetic code. Genetic testing would be easy enough if all of our genes were spelled the same way. But the truth is there's a fair amount of normal variability from one person to another. And so sometimes interpreting the genetic code is tricky. And that's part of why it's helpful to be tested by someone who really knows about genetic testing and can make the proper interpretations. So what do we know about these genes, BRCA1 and 2, and specifically mutations in the Ashkenazi Jewish community? So we know Ashkenazi Jews, first of all, are individuals with Jewish ancestry, and their ancestry is from Eastern Europe. And about 90 to 95% of the Jewish population in this country is of Ashkenazi Jewish population. So people from Lithuania, Germany, Poland, Russia, all Ashkenazi Jews. And we know that if someone is of Ashkenazi Jewish ancestry, that they have a higher chance of having inherited risk due to either BRCA1 and 2. And that increased risk is all due to three specific mutations, or as I call them, three specific misspellings. And here on the slide, I have the two genes represented, the BRCA1 and the BRCA2 gene. And you can see there's two places highlighted by the green arrows in the BRCA1 gene where specific misspellings are described. So the first one, 187DELAG, is a specific description of what we call a founder mutation. It's a common spelling change in the BRCA1 that we see in the Jewish community. It is an ancient mutation. It's been around for thousands of years. We see this second one in BRCA1 called 5385INSC. It is common among people of Eastern European ancestry in general, including the Ashkenazi Jewish population, but it's present in other individuals of Eastern European heritage as well. And then there is a common founder mutation, specific spelling change in the BRCA2 gene shown below. These genes are really very large. So for example, the BRCA2 gene is spelled with 20,000 different letters. And these are just a few letters that we see that represent these founder mutations. We know that if someone is of Ashkenazi Jewish descent and has a mutation in either BRCA1 or 2, there is about a 90% chance that it will be one of these three changes. And that's just due to common shared genetic ancestry. Common shared ancestors, literally common snippets of DNA that were inherited from shared ancestors. It's a genetically more similar population because historically it's been a population that's been known to have children among themselves. And so first of all, how much cancer is due to strong hereditary cancer risk? About 10%. We know that Ashkenazi Jewish ancestry, though, is a predictor, again, based on that common shared genetic ancestry. So what are some of the clues that we can get from a family history that inform us that there may be more chance that we will find there is hereditary cancer risk present? And when I say hereditary cancer risk, I just want to take a moment to define what I mean by that. We know that cancer, as I said, most of the time, about 90% of the time, is not due to you inheriting a mutation in a single powerful gene, but rather it's a combination of things. There's maybe a whole set of genes, each with just a little bit of an impact, but all together can create a little bit of a profile of risk, combined with environment and lifestyle, and largely just random cell errors that happen over one's lifetime. So most cancer is not due to a single powerful gene that you inherited, but a small percentage is, and it's very important when that's present to know about it. And the clues that we get about the presence of this risk include there's more cancer than expected in the family. So we know that cancer is fairly common. Most families, if you take their history, will have at least one or a few relatives who've had some form of cancer. But we look at how many, and is there more than you would expect just due to chance alone, or sometimes the way I call it, more than a family's fair share. We look to see, are there multiple generations of cancer or related forms of cancer? So crossing one generation to the next, looking like something is running from parent to child and parent to child. We look at the ages at which people were diagnosed with their cancers in the family. And if you're genetically predisposed, it's more likely we'll see that cancer develop at a younger age because less has to happen if you are predisposed in order for that cancer to appear. We look for less common types of cancer in a family, such as ovarian cancer, pancreatic cancer, metastatic or more advanced prostate cancer or male breast cancer, or other forms of rare cancer. That can be a sign that there is some sort of hereditary risk. Seeing people who themselves have more than one form of cancer. So for example, a woman who has both breast and ovarian cancer, or a man who has both prostate cancer and melanoma, that can be a reflection of hereditary risk. But getting back to this idea of, why do people who have Jewish ancestry and have common shared ancestors, why does this lead to a higher rate of having mutations in BRCA1 and BRCA2 specifically? So there is something called a founder effect. And this is what it is. If you have an initial population, which is reflected on the left side here, and you can see only one person has that little red mark on their chest, so it's not that common. But then if the population size is reduced, and we think this is what happened in the Middle Ages in Europe, the Ashkenazi Jewish population, or just the population of Jews in the Middle Ages in Europe, was very small. And it's easy to have something be overrepresented. So there's only 5 people in the middle picture there, and that's 20% of the population. It didn't start out that way, but then the descendants of that population will all have this mutation or these mutations overrepresented in it. And so that's the founder effect. And that's one of the reasons that we see a higher rate of having BRCA1 and 2 mutations in the Jewish community. Based on this knowledge, there's been a major national study that some of you might have heard of called the Before study. And it was one of the first studies in this country to offer population-based testing. So not based on any family history specifically, but just knowing that if you have Jewish ancestry, you're eligible just based on that to consider genetic testing. Your chance is 1 in 40 as compared to about 1 in 400. So that is a 10-fold higher chance. It's very significant. Enrollment for this study was recently completed. There were about 4,500 people who've participated. And it was a national study at Beth Israel, at Dana-Farber, at Memorial Sloan Kettering, UPenn, Cedars-Sinai. And it tested out a way to offer genetic testing to try to get it out there more easily so that people could watch information online and then get genetic testing with the assistance of their primary care physicians. And so the results of the study are going to be presented at a national meeting in this upcoming month. And we hope that this will be one among many studies that will continue to show the value of doing outreach on population-based testing for Ashkenazi Jewish families. So why is this important? Why should someone be interested in getting this information? So here I have a chart that is just showing the difference between someone's chances of developing these cancers in the setting of a BRCA1 or a BRCA2 mutation compared to someone who has average risk. So for a woman, if you have a mutation in BRCA1 or BRCA2, your lifetime chance is somewhere between 50 to 80%. Compared to the average woman's risk, which is about 12 to 13%. So obviously that's very different. We're gonna do things very differently too for someone whose chances are elevated in this manner. For women who's been diagnosed with breast cancer, we know if she has a mutation in either gene, that her chance to develop another breast cancer, not a return of the one that she already had diagnosed, but a new one, is also much higher. And so sometimes at the time of diagnosis, genetic testing is offered because it might affect someone's choice for what type of surgery she wants. We know ovarian cancer risk is significantly higher with both genes. It's higher with the BRCA1 gene versus the BRCA2 gene. The average woman has only a 1 to 2% chance. And then there are some other cancer risks that are elevated as well, although not as much. Melanoma, pancreatic cancer, male breast cancer, and prostate cancer. And so this is really the crux of the matter, I think. We call it risk management. The fact that there are things to do to make one's situation better, to reduce risks, to screen in a way that maximizes the chances of early diagnosis. All of these things can affect good outcomes in families who carry these mutations if they know about them. So as examples here, surveillance for someone who has a BRCA mutation. If you're a woman, we start MRI, breast MRI screening at age 25. So first of all, breast MRI screening in the absence of symptoms is not offered in general to any women. It is not a routine, even among women who've had breast cancer. And so this is really something very different. And starting at age 25 is something we rarely suggest, except in these sorts of situations. We add mammography at age 30 And then typically we alternate every 6 months between mammography and breast MRI. Clinical breast exams by an expert, usually every 6 months. For men, there is this increased risk, especially with the BRCA2 gene, for a more aggressive type of prostate cancer, possibly at earlier ages. So we start doing prostate screening also earlier. In families that have BRCA mutations and have a family history of pancreatic cancer as well, there is screening now that is being done using endoscopic ultrasound and an MRI procedure called MRCP. And it is just a detailed look with the MRI scanner at the pancreas. And the hope is, and the data is showing, that if you screen intentionally for pancreatic cancer, that you can find it at an earlier stage than if one waited until symptoms developed. There are opportunities to do preventive surgery, like bilateral mastectomy is effective. There are interventions such as removing ovaries and fallopian tubes at the right time, generally after someone has gone through their childbearing years. And these surgeries can have a major, major impact on your overall chance of ever developing a cancer. These are very personal decisions, and we talk to everyone carefully about not just should this intervention be chosen, but the when is the best time for the specific woman to do this is also very important. There's a whole field that we call chemoprevention, or taking a medicine to lower the chances of ever developing a cancer. And these options are also offered to the appropriate women. One of the newer things I wanted to share is this idea that there are other cancers beyond, we tend to think about the BRCA genes and breast and ovarian cancer mostly, and that's because the risks are higher. But there is a big study that was published fairly recently that looked at men with metastatic prostate cancer specifically, and we found that almost 12% of men, just based on that diagnosis, had a mutation in one of a number of different genes. And you can see here in this pie chart, the BRCA2 gene was the most common gene that was altered among these men with metastatic prostate cancer. And because of that now, it has become a national guideline that if we encounter a gentleman who has high-risk prostate cancer or metastatic prostate cancer, that alone is a reason to offer genetic testing. And again, BRCA2 is among the most common things that we find. There is specific targeted therapy now available for individuals who have these BRCA mutations. So sometimes the tailoring is trying to find out if someone has inherited genetic risk due to a BRCA1 or 2 gene, because it's going to change the drug of choice their oncologist selects for optimal treatment. So here are just some examples of things that we are doing at Dana-Farber, and there are many other studies around the country and interventions for those who have, for example, pancreatic cancer risk, where the drug of choice is tailored based on the presence of a gene such as BRCA2. Mm-hmm. And so we know that there are these terrific opportunities to have special screening and do things differently, but what about now in this time when things are on such lockdown? How are we thinking about screening? How are we thinking about genetic testing? So, first of all, as you've probably seen, there is in general an emphasis for all medical centers to try to minimize the need for in-person encounters. And one of the things that this pandemic certainly brought about was an instant adoption of telemedicine and video conferencing options. It's not like these technologies are new, let's be clear. They've been around for a long time. What is new is that you can actually bill for these services, and it's possible to actually run your clinic and get reimbursed for the patients you see now using these technologies. And it's a win-win, I think, all around. It's the case in most centers where unless you are there needing treatment, so you're there for your infusion because you're getting a cancer a cancer therapy, then you don't need to be in the building in order to minimize your risks. And so sometimes conversations about things like screening, about genetic testing, if you're recently diagnosed with a cancer, about surgical choices, or choices of we could do this regimen or that regimen for your chemotherapy, all of those discussions are happening remotely. And it's actually kind of a nice thing for those of us in Boston. No one really relishes driving into Boston and parking in our garage. You can teleconference your support person in, your partner, someone else, maybe your very helpful sibling who lives across the country. Everyone can be present. It's really a nice technology. And I expect that some of this, I'm hoping, will hang around even after COVID-19 is over. And so in order to protect our cancer patients, our policy at Dana-Farber, and again at many centers, is that there's no one in the building who does not need to be there. So you're either there specifically for treatment. There are no visitors. You cannot bring a support person in. If you arrive at our center, then someone will escort you if you need assistance getting up to the floor for your treatment, or you will just go yourself. And this is a very painful process for many folks. And that's, among the many painful things about COVID-19 is that in order to try to minimize risk for getting this, it means there's a lot more isolation than we would like to see. But right now, this is the policy. Things may open up down the road, but this is how it is for now. And this has also led to the deferral of routine screening. If you don't have a symptom, there's been really no screening available in many places around the country. In our own center, we are going to be resuming routine screening starting June 1st. And the individual dates where screening will resume, of course, is going to depend on the state, the institution, and what the local policy is. So it is something to check in with your local providers. The deferral of routine screening will not go on forever. And I know at our institution, there is a prioritization of getting people back who are at high risk. And this is one of the reasons it's helpful to know your status. If you know that you have inherited something that increases your risks for developing a cancer, you get a high priority in terms of coming for screening. And in general, the way people will follow you with, I say the biggest magnifying glass when they're looking at your films and level of care, because this is a feature that's important to know about. There's been a deferral, as most of you have heard, for elective surgery. And to be clear, elective surgery doesn't mean just things like plastic surgery. Elective surgery is just anything that is planned, as opposed to urgent surgery, where it just has to be done now. And so the elective surgeries are coming back. They've started already in a number of institutions, and they're going to continue to come back as things start to settle down a little bit with the number of patients needing care for COVID-19. And for our cancer patients, what this has meant is sometimes trying to do treatment like chemotherapy first, and then doing cancer surgery second. And that is a very successful way for many people to manage their cancer anyway. And this has been a preferred approach in order, again, to just keep people as safe as possible. In this time period, it is important to remember that there are still services available. And there are great lengths taken at most institutions to try to keep our patients safe. And that if you do have a symptom, it is important to let your doctor know. There still are services available for those who need to be worked up on a diagnostic basis, and that can often still be achieved. Well, what about genetic testing now in this time, and not wanting to come in? And is this something that we should all think about doing 23andMe? So here's a picture of, I think this is in the Target, And remember going to the Target? And here you can see these 23andMe kits that are for sale, direct to consumer. This has been something that many people are interested in. It allows them to take charge of their own genetic health. They can do the genetic testing at home on their own terms. And it sometimes can provide interesting ancestry information. That's a lot of fun to learn. But what about the validity and the information you get on one of these take-home kinds of tests that you can just purchase at the Target versus the type of medical grade testing that you would get if you worked through a genetics service such as ours, but not only ours. These are all around the country. There was a very concerning publication that came out recently that looked at the number of false positives. So people who were told that they carried a mutation in a gene that turned out to be wrong from these direct-to-consumer genetic testing companies. It's very concerning, and this is a problem, and what I call it's not medical grade testing. The type of testing, the lab methodology is different in a test like 23andMe, which does something called SNP testing. It is very different from what we do, where the genetic code is examined from the beginning to the end. And part of the difficulty interpreting the results has to do with, it's a very different lab pipeline. So yeah. So then what is one to do? It is still possible to have genetic counseling and testing safely in a remote way. There is a National Society of Genetic Counselors that maintains a website where you can see right on the front, there's a genetic counselor search tool. You can put the state or the city that you live in, and it will identify genetic counselors in your part of the world. It's also a good idea to ask your physician or nurse that you're working with who they recommend for genetic counseling and testing, and they may be able to provide a reference. And there are some online companies that do medical grade genetic testing. So this is not the 23andMe, but there's a company called Invitae Genetics. They will do an excellent genetic test, and they can provide you with a genetic counselor for a fee that can do it remotely. Color Genomics is another company that does high quality genetic testing that can be done by making arrangements online. And then there are companies such as Informed DNA, where they offer telephone genetic counseling with certified genetic counselors who can help you understand these issues and make your own arrangements for genetic testing. So there are a number of options. And the way we do genetic testing nowadays remotely is by using a saliva kit. And the one you see here on the left is the one that virtually everyone uses, the Origene kit. And it comes in a box from the lab, and it comes with instructions, and it's really pretty easy to use. You can see there's a tube with a special cap. You literally spit into the tube, you fill up the saliva up to the line, you press the cap down, and it releases a reagent into the saliva. You mix it around, you replace the cap, and now it's good to go. The kits come generally with prepaid FedEx mailing labels. They can go in a Dropbox, and they go directly back to the lab. And so we have these kits sent directly to people's home. You can do this at home, send it in, and then the genetic counseling itself is offered in a variety of ways. We're doing it by Zoom. We're doing it by telephone. You know, there are a variety of ways we can offer this remotely. All the Boston area cancer genetics program have this service available, and many cancer genetics programs across the country do have this same type of availability. I just wanted to say a little something about the fact that BRCA1 and 2 are not the only genes that can increase the risk for cancer. They are the ones that we know there's an increased incidence for in the Ashkenazi Jewish community, but there are other genes, and there are other genetic testing options beyond just looking at the BRCA1 and 2 genes. And this is something that a genetic counselor would discuss with you based on what they're seeing in your family history. So for example, there's a condition called Lynch syndrome, where someone lives their life at a much elevated risk for developing colon cancer. We start colonoscopies in the 20s, and we do them every year. There's a gene called HOXB13 that results in a markedly increased risk for prostate cancer that also affects follow-up. And so we can do a variety of different test types, and we try to make sense of what is the best option per the individual. So in summary, why do population screening? We know we can reduce the chances of developing a cancer, that these interventions can be life-saving, that it gives families a way to make sure that the people who need this are getting this, the people who need that, because maybe they did not inherit the risk that's in the family, don't need to do those things. There have been cost-benefit studies done. So on a policy basis, it makes economic sense. There's been work shown that having just one Jewish grandparent is enough to justify this screening in the population. And so I'm going to stop there, and I will be very happy to take your questions.
Thank you, Jill. I'm just going to, if you stop your screen share, then I can, okay. Thank you. We did have some questions that were, you might have already covered them. Let me just get to those. A couple questions that were submitted to us prior to the webinar this evening. You already talked about how testing is being done during COVID-19, covered the at-home test kits. I haven't gotten anything from the attendees online right now. I think you did cover too how you found a genetic counselor during this time, through a couple different websites, the National Society of Genetic Counselors. Are there any other websites that might be helpful, whether they go to the major health institutions in their area? How else can you direct folks to find a genetic counselor? How should they go about doing that?
Right. So, other than talking to your own providers, there is also a search tool that is embedded within the National Cancer Institute's website. And that's something that can be checked. And there are some, there's a national organization called FORCE, Facing Our Risk of Cancer Empowered, that has helpful information specifically to the community of folks who have BRCA concerns.
I think, did you cover, just one more question was how, you just found out you're BRCA positive, you've gotten your test, you've been screened, you might have had a session with your genetic counselor. What does somebody do with that information once they find out they are BRCA positive? So
we are still, testing people now, and then we reconvene. Generally, if there's a positive result, then we recommend following up with a cancer genetics physician and the genetic counselor, and we have a very detailed discussion of, which gene is it that has the issue. There are some differences between BRCA1 and 2. We help people understand their specific risks as well as their risks over time. And I think a lot of the information that gets presented, and even what I showed in this short presentation tonight, is just, what's your lifetime chance? But that chance is really spread out over your lifetime. And we help people figure out what is the right move, or what is the right thing to do, what is the right choice for how to manage this risk based on your age right now, and what do you want to defer for the future. And so all of those conversations are happening now via, again, these remote access ways. So through teleconference, through Zooms, through phone calls. This is a lifetime issue. And so if you identify genetic risk now, this information is not just for the immediate future, it's for the long haul. And so this isn't a bad time to try to understand what's going on with an eye toward, this is something I'm going to be enacting and something I'm going to be managing, in perpetuity.
Okay, great. I think we covered pretty much every other question that was presented to us. And I don't see any from our attendees right now. Just in addition to
the one
the
thing I didn't
resources.
talk about was the insurance.
Okay, yeah, sorry. It's testing covered by my insurance. Or how do you find that out, you know?
Right, right. And so the truth is, for most people who are good candidates for genetic testing, meaning, you know, there's some reason for you to have it, and having Ashkenazi Jewish ancestry and having any family history of any of these things typically will result in coverage. So most people will have coverage, and generally when we submit these samples, we submit with insurance information, and we do our best to try to get everyone covered. It's important to know that the cost of genetic testing has come down dramatically. And so even people who find at the end of the day, just due to all the differences between insurance companies and different policies, the out-of-pocket cost, even for a very comprehensive panel test where we're looking at many genes at once, is usually no more than $250. That's usually the maximum out-of-pocket. And most people will pay significantly less than that. The laboratories that we use also generally have really nice support available for people who have lower incomes or meet certain guidelines. So we find we're able to get just about everyone tested who is a good candidate that wants to go ahead and do it.
I'm sorry, let me just take myself off mute here. We did have somebody who raised their hand. Let me just see if I can find that question for you. Hold on one second, okay, Jill?
Sure.
Okay. I'm just going to encourage the person who is asking the question to type it into the chat, the Q&A, so I can read that to Jill when you get a chance, and we'll try to answer that in the next before we wrap up. I did want to thank you, Jill, for taking the time this evening to present all the recent updates. I certainly learned even more this evening, so thank you for that. I'm sure all of our attendees did as well. Like I was just saying, in addition to the resources Jill had mentioned, we also, I'll be putting these on our website, but Oneinforty's website, the CDC has a lot of good information. Jill mentioned the National Society of Genetic Counselors. There's also a local resource for folks who are, located in Massachusetts. There's the Virginia Thurston Healing Garden Cancer Support Center. They have a lot of wonderful information and resources out there for folks. Along, we touched upon how to find a genetic counselor, or how to find, there's a listing of, on the American Cancer Society, there's a listing of, the U.S. cancer centers, most of which that have departments that offer genetic counseling and screening. Just once again, wanted to thank our sponsors. I'm sorry, I apologize. My son is in the background. He's not feeling well, so it's part of the world we live in right now. He's just not feeling so good.
Yeah.
So if you hear that, I just wanted to thank our sponsors once again: the Allergan Foundation, Pfizer, New England Development, AstraZeneca, Clovis, Tesaro, and Goldstein and Bilodeau. And as I mentioned, after this webinar, everybody will receive a brief survey. If you can kindly fill that out, we'd greatly appreciate that. And then I just wanted to make note about our next upcoming webinar, which is going to be held on June 4th with our guest speaker, Dr. Leif Ellison from MGH. He's the program director for breast medical oncology. All right, Jill, so I think we got the question in. Just let me read it to you, okay? I don't know if you can see it on the screen.
Yeah.
I have had, okay, I was hoping that'd be anonymous. I have had aggressive, let me stop share for 1 second. Okay. I've had aggressive ulcerative colitis and now dealing with aggressive prostatic cancer. Should I get genetic testing?
So if that's a prostate cancer, the aggressive prostate cancer, or very high Gleason score prostate cancer, if that's what that's about, then genetic testing is recommended at this point for a few reasons. Again, for a gentleman who has an aggressive prostate cancer, if we do discover that you have a mutation in a gene such as BRCA2, it can affect your physician's drug of choice. Sometimes it doesn't affect anything immediately. If you're currently in treatment and something is already underway, it may not change what you're doing right now. But in the course of cancer care, it's pretty common that a time comes when we need to switch the medicine to something else. And then the information from genetic testing, if it's there, it can be used as a very important data point that can be considered and thought through. And it may be that the next choice will be influenced by that knowledge, having the genetic testing knowledge there about inherited genetic risk due to a gene such as BRCA2. So yes, it can be a helpful thing to do.
Okay. And to the attendee that did pose that question, if you need some more follow-up information to that, certainly reach out to myself and I can connect you with the right person and find out that information for you, or further information for you. I'm sorry. I think I just wanted to get back to my sponsor slide. Get back to, yeah, so I was just saying that our next webinar, it's okay for me, our next webinar will be taking place on June 4th at 2 p.m. featuring Dr. Ellison. I'm so sorry, everybody. And he will be covering, updates on hereditary cancer as it relates to COVID-19. So with that being said, I thank Jill for participating this evening. Again, I do apologize, but I thank you, Jill, for taking the time out of your schedule this evening. And on behalf of Oneinforty and our sponsors, and on behalf of all of us, I thank you for attending this webinar this evening. Okay. Thank you.